Hi, this is Dr. A with a Clean Camera Review video, and we'll look at some intro concepts on tumor markers. Alright, so first let's talk about cancer. It's the second leading cause of death in developed countries, accounting for 23% of death in the United States and approximately 3 million deaths a year globally. That is a lot. Biologically, cancer refers to the uncontrolled growth of cells that often forms a solid mass or tumor, which is a neoplasm, and spreads to other areas of the body. The formation and spreading is called metastasis, of the tumors is caused by a complex combination of inherited and acquired genetic mutations. During tumorigenesis, mutations will activate growth factors and oncogenes in combination with inhibiting apoptosis, which is the death of cells, and the tumor suppressor genes and the cell cycle regulation genes and stuff. So the bad stuff gets turned on and the good stuff basically gets turned off. So again, the causes of cancer: inherited genetic mutations. There are certain mutations that make you a little bit more likely to have it, like, for example, that BRCA gene for breast cancer. Acquired genetic mutations, these could be acquired through like environmental exposures and stuff like that. And then your proto-oncogenes are normal genes that are altered by mutation that then become cancerous. And of course, your tumor suppressor genes, they are part of, your immune system and things, where those genes are always looking to, turn off the growth and, the tumor suppressor genes. And so if those get inactivated, then there's nothing to keep the, those mutations in check, and those cancer cells can grow out of control. And there's also epigenetic gene silencing. And so this is where the good genes that lead to health and stuff like that get silent, and epigenetic modifications are modification of how the genetic code is expressed, not so much modification of the underlying code. So it's basically whether the gene is turned on or turned off. That's epigenetics. And so the gene silencing would be obviously, silencing the health genes, silencing the tumor suppression genes, and all that kind of stuff through epigenetic changes. A few definitions. Neoplasm is an abnormal growth of cells with no physiological purpose. Some tumors can be benign, others can be malignant. Benign tumors usually kind of are self-contained. They're not growing out of control, and they're usually very slower progressing, and basically they're non-cancerous. And then a malignant one is a cancerous tumor. Those grow, they get bigger and bigger, they can grow out of control, and they can spread, which means, metastasize, spread. Carcinoma in situ is a pre-invasive cancer. It's from the lining cells, but it has not spread yet. So that's what carcinoma in situ means. And then tumors can be classified. They're usually named after the type of cells from which they arise. So for example, an adenoma arises from, adeno means gland, so from a gland, and it's a benign tumor, whereas an adenocarcinoma, if you add the carci root for carcinogen for cancer, it also arises from a gland because of the adeno but it's malignant because of the carcinoma. A fibroma arises from fibrous tissue and is benign, but a fibrosarcoma, sarco means actually flesh, it arises from fibrous tissue, but it is malignant. Again, carcinomas tend to originate in the epithelium. The epithelium is what lines our body and our cavities and organs and everything like that. So it's basically the first line of exposure, first line of defense, and so that's usually where your cancers will come from. Sarcomas, though, originate in connective tissue. So cancer is often staged, and is staged based on tumor size, histology, regional lymph node involvement, and the presence of metastasis. Cancer staging will require a physical exam, a medical history, and diagnostic imaging. So stage 0 is carcinoma in situ, so it's an early form. Stage 1 is localized, so it hasn't spread yet. Stage 2 is early locally advanced, so it may have spread to a few nearby lymph nodes, or so it's starting to get out of control a little bit. Late locally advanced, and it's definitely, you know, spread even more through the lymphatic system and all that. And in stage 4, it's metastasized, which means that you can find those cancer cells in other sites of the body. So for example, let's take an example of breast cancer. Breast cancer that has metastasized, for example, to the liver, you are seeing the breast cancer cells in the liver. And so it's not that they have liver cancer, it's just that they have breast cancer that has spread to the liver. It's a different type of cells that are moving around and stuff. Cancer can also be graded. It is usually, grading is based on pathological examination. Again, you have grade 1 or 2. So seen under the microscope, grade 1 or 2 cells are abnormal, but they still appear to be organized in rings. This may indicate a slow-growing cancer. Grade 3 cells will vary more in size and shape. Fewer rings are visible. These cancer cells may grow more rapidly or still be slow growing. And then grade 4 or 5, they form irregularly closely packed rings, or they don't form rings at all. They vary even more in size and shape than lower grade cells, and these grades indicate a fast growing cancer. So again, this is more, the cancer grading obviously here is more based on simply on pathology. So again, metastasis is the spread of disease from one site to another. The cells from the initial tumor, initial cancer, can break loose from the main tumor, and then they can be carried either via the circulatory system or the lymphatic system. It kind of just depends on the type of cancer. A little bit of the timeline of tumor development and tumor markers and stuff like that. So if you are screening for cancer, the only tumor marker that's useful is the PSA, and it would then indicate a need for biopsy if it was elevated. The then next stage of assessing cancer is going to be diagnosis. So some of these, so your metanephrines, which come from your catecholamines, so HVA and VMA, homovanillic acid and vanillamandelic acid, I think, something like that. Anyway, HVA, VMA, they are going to be elevated. Prolactin, parathyroid hormone, chromogranin A, cortisol, ACTH, those are all markers that can be used, and then high levels of those would indicate that presence of the disease, and they're only a part of the diagnosis. Then for prognosis, so again, how bad is it? High levels are associated with poor prognosis in the B2 microglobulin, the CA125, the CEA, LD, HER2, and NU, and ER and PR, estrogen receptor, progesterone receptor. Then for treatment monitoring, to see how the either cancer, chemotherapy, or radiation therapy is going. The ones that can be used a lot of times are some of the ones that are used with prognosis and or diagnosis, but CA125, CA19-9, CEA, AFP, HCG, PSA, and SPE, serum protein electrophoresis. All of these can be used to monitor treatments. And basically, if you have surgery, maybe they're removing a tumor via surgery and stuff like that, you should see a drop of these. And if they come back up, then it means that the disease is coming back. So that would be then detection of recurrence. So again, any increased levels are associated with relapse, especially if there was a drop before that. And so CA15-3, CA125, CEA, AFP, HCG, and PSA are all used for the purpose. So a little bit more on applications of the tumor marker detection. So screening. So an ideal tumor marker would be tumor specific, absent in healthy individuals, and readily detectable in body fluids. There just aren't that many that meet that criteria. There are numerous tumor markers that have been identified, and they have a high enough specificity and sensitivity, But you really want to use them in combination with clinical signs and symptoms, histology, and all of that to facilitate the decision making. Because some of these tumor markers can be they can be present in healthy people, and so it's hard to use them for screening. So the only tumor marker that is widely used for screening populations for cancer is the PSA. And that is used to screen for prostatic cancer. And you can also potentially test for the susceptibility to cancer using molecular diagnostics in patient with breast, ovarian, and colon cancer, and you're looking for germline mutations in patients with a family history of breast, ovarian, and colon cancer. So prognosis, the tumor marker concentrations will gradually increase with tumor progression, reaching the highest levels when the tumor metastasizes. So your tumor marker levels at diagnosis can reflect the presence of malignancy and aggressiveness of the tumor and help predict outcomes. Basically, the higher those tumor marker levels are going to be, the poorer the prognosis is. And then lastly, they are used to monitor therapy effectiveness and disease recurrence. So again, after surgical resection, radiation, chemotherapy, all of that, the tumor markers are often routinely followed serially, meaning they do them over time. And if the patient had elevated tumor markers at diagnosis, then effective therapy will show a dramatic decrease or complete disappearance of the tumor markers. Now, if they did not have elevated tumor markers at diagnosis, then you can't use those tumor markers to monitor effectiveness or do disease recurrence, because it's just not being produced by the tumor. So many tumor markers, though, have a lead time of several months before the disease will be detected by other modalities, such as imaging. So think, CTs, X-rays, etc., which then that allows for an earlier identification and treatment in cases of relapse. And the results, when you do these, the results that you're looking at have to state the methodology and the instrument used, because tumor marker results will vary from different manufacturers and they cannot be used interchangeably. So this is especially important if a patient's going from one facility to another or something like that. So if the patient is changing location, changing labs, and then it's a change of methodology, then you often need to re-baseline the patients, which is accomplished by just running the patient specimens on both an old and a new method and reporting both to the physician. But anyway, you just need to know that you cannot compare from one manufacturer to another. If you're following them serially, it needs to be all with the same method, same analyzer, etc., etc. And that's it. Thank you.